the Bald Oncologist podcast series, featuring Dr. Malwinder.
Hello everyone, welcome to the next episode of the Bald Oncologist podcast. It's a special for the breast cancer month. So we are in the month of October and we're going to be talking a lot about breast cancer. So in our studio today, we have Dr. Mastura. She's my mentor and she's also my colleague right now. She's a clinical oncologist. So we'll be discussing more on the treatment options for breast cancer. So Dr. Mastura, a common myth what cancer patients always have is that after surgery, they're going to need chemo. Is it true, or is there any other options, or must everybody just go through chemo, or surgery is just enough? What are your thoughts?
Okay. As we know, if somebody has had surgery for breast cancer, that means that this patient has been treated for cure.
True.
Right? So after surgery has been done, chemotherapy are basically drugs that we give in addition to surgery, in addition to radiotherapy, maybe hormonal therapy, in order for us to reduce the patient's risk for recurrence, right? As well as trying to get the patient to live a longer life,
Correct.
increase the survival of the patient. But chemo also has its own side effects. So chemo acts by acting on fast-growing cancer cells. So our normal cells are also fast-growing cells, such as the bone marrow, the gut. So because of this, we have to be selective in who are the people that we want to give chemotherapy for those aims. So those patients that we would give chemo are those patients that have risk. Okay, who are the patients that have risk? So in the patient's cancer report characteristics, right? So there are a few things that we will look at in order for us to risk classify the patient as having high risk for recurrence or not. So how large is the size of the tumor? What is the number of lymph nodes that are involved? What is the grade? What is the 𝐾CC7, which are basically characteristics of the cancer that tells us how fast the cancer grows.
So everybody's tumor is actually different, right? Everybody has a different biology.
Yeah. But this will be the information that will be available for the patient every time if they have early breast cancer. And then, of course, so those are basically the stage, right? And then whether the cancer has spread anywhere else, of course. And then the tumor biology. Tumor biology tells us about the behavior of the cancer. So either the cancer expresses hormone positivity, or the cancer has extra number of HER2, which is a protein that is responsible for growth. Or maybe the cancer is on the subtype called triple-negative breast cancer. So that is a tumor biology that we all look at. Then there are also other characteristics like how young is the patient, how old is the patient. Because young age cancer diagnosis tells us that the cancer is aggressive. So we will consider them to be at risk. Next would be what is the patient's susceptibility to get cancer, where the patient carries the germline BRCA mutation, means that they were born with the inheritance for that gene that increases their risk for cancer and cancer recurrence. The last thing is actually whether the cancer has some genomic or genetic characteristics that increases the risk of recurrence. So this is something that we can test in the patient, what we call the gene expression profile. So like 𝐂𝐡𝐞𝐤 or mama print or procyanea, these are tests that we can do after the surgery in order for us to decide whether this patient needs or not the chemotherapy.
But these tests are all usually at a very early stage, right? If you're diagnosed like quite late stage with a lot of lymph nodes, there's no point of doing those tests, right?
So there are two categories of patients that we will do this test. So those patients who have no lymph nodes, but there are no lymph nodes, but maybe they have, like, for example, a higher grade. And there are patients who have lesser number of nodes, small tumor, lesser number of nodes, maybe 1 to 3. So you just want to say, this patient needs chemotherapy or not, because there is no positivity. But when we do the genomic expression profile, the genomic the result is actually no score. So although this patient has one lymph node involved or two lymph nodes involved, genetically the tumor has no recurrence risk. So we do not need to give the patient's chemo.
Okay, but how accurate are these tests in our Malaysian population?
Well, these tests have been performed on a large number of patients, and they have categorized the patients as in older age, postmenopausal or premenopausal. So the number of patients who are premenopausal in our patient population is actually more. So we have to take the test results to guide our decision with caution.
Yeah.
For example, of course, I will not do oncotype DX in my patients who are like 30 years old at diagnosis, because the age itself, 30 at diagnosis, is already for me a risk.
So risk factor.
So yeah, so we will do this. So it's an art around the. So it's not
So you
just
have to pick and
science.
choose.
So we have to. It's an art.
Okay. So what about stage 4 cancer? Is there only chemo the option, or there are many new drugs which is available?
Okay, very good question, because in stage 4 patients, a lot of people look at them like they have, no hope, basically.
Yes.
But in the last 10 years, we have seen an explosion of new innovation in cancer, and people really look into what is the biological characteristics of the cancer. So now we are looking at, okay, if you are HER2 positive type of breast cancers, you have newer drugs. I will go to that in a while. If you are hormone receptor positive, HER2 negative, then you have this group of drugs to use. And then if you have triple negative breast cancer, you have another group of drugs to use. In each of these respective groups, we have basically improved the patient's survival, as well as improved their quality of life. In really like if let's say for triple negative breast cancer, patient used to have a survival of about 1 year. Now with immunotherapy added to chemotherapy, in this patient you can have survival 3 to 5 years. In HER2 positive type of breast cancer, if you give them a good HER2 drug with the chemo, now it's 8-year survival in about 40-45% of patients. If you are hormone receptor positive, HER2 negative, you can take tablet. They are called CDK4/6 inhibitors. In Malaysia, we have 3 types of tablets that we can give on top of the normal hormones. And this patient, it's like 6, 8, maybe more, maybe 10 years. So we are now curing
It, so we're making it as chronic as possible.
It's not like diabetes or hypertension where you give patient pills and they take on pills after pills and they just leave. So we are now curing stage 4 cancers. So it's no longer like 6 months or 1 year.
So how long? What's the longest survival you have for a breast cancer patient?
A patient of mine, I just saw her last week actually. She is now 53 years old.
Okay.
She was diagnosed in 2008 with breast cancer that has spread to her brain, lung, liver, and bones.
Okay.
So she's hormone receptor positive, HER2 negative. She has had the standard chemotherapy first, and then she has had at least 3 lines of hormonal treatment.
Okay.
Plus radiotherapy, plus some procedures to her bone metastasis. But she's living life just like us. She goes hiking with her husband. When she comes to see me in the clinic, she uses a motorbike.
Like a normal person.
She rides a motorbike with her husband to help her. So she comes every 3 months now to get her she's not on aromasin, so it's just aromasin only. But she's on Tajin now because she has a lot of bone metastasis, and it has been 2008 until now. It's like
So very good. So why?
15 years, I think, now. 15 years for brain, bone, nipple, and lung.
Yeah, that's actually.
So she's probably the longest and the longest.
Okay. So what are we looking forward for? Any new advancement? What are the latest technology available for our breast cancer patients?
For breast cancer, I think the latest kit on the block will be the antibody drug conjugates. So after the CDK4, we had targeted therapy, and then we have CDK4 inhibitor, and then we have immunotherapy. But the latest one will be the antibody drug conjugate. So this is like a super bullet because you have a monoclonal antibody which is targeting the target that you could identify within the patient's tumor, and then this monoclonal antibody carries with it the bullets. So the bullets are the drug that is selectively carried in the bloodstream, and then is only released at the target, which is the tumor cells. So basically you have a vehicle that carries a very active substance that is only delivered to your target, which is the cancer cell. So when you do that, you kill the cancer cell, but you spare the normal tissue from getting the side effect of the drug. So that's why this is basically the latest at the moment. And in addition to this antibody drug conjugate, people are now also looking at targets that used to be a target that have to be there in order for the drug to be effective. Now it's like the target doesn't have to be there.
Don't quite really understand.
It's like,
what do you
if let's say, for example, if you have HER2 positive type of breast cancer last time, in order for you to use an anti-HER2 drug, you have to have the HER2
Yes, correct.
present in your cell, in your cancer cells, in order for the drug to be effective. Now, when you can have just HER2 low,
HER2 low, yes.
or like, no number of the HER2, or maybe absence of HER2, or super low or absence of the HER2, yet you still can use the drug.
Okay.
And it will still be effective. So that's where we are going to go to, I think, in the future. And subsequently, I think, will be all the artificial intelligence advancement where you could use systems to guide
Our treatment options.
treatment options.
Okay, so how much does this drug normally cost?
Okay.
Is it new technology? Always it will be very expensive.
Yeah, you're right. So that's a knife in the heart.
Yeah.
So usually they cost around 20,000 like that.
Per cycle.
Cycle.
So that's quite pricey.
But we do have clinical trials.
Yeah, so I was coming to that.
So the other thing that we need to really look forward to is actually the number of clinical trials that we are getting in our country, both in public and private industry, where we could have access to all these drugs, and therefore our patients can benefit from it, including their group.
So how do one patient actually enroll in a clinical trial? Is there like a website or something which they can go and find?
Okay, so in our society's website, we have a society called Malaysian Oncologist Society. We have a website that we proactively basically allow the public to see what clinical trials are being conducted in various centers all over Malaysia. So at that site, we tell you, like, for example, if you are looking for a lung cancer trial or you're looking for a breast cancer trial, then you can just go to those lists and you can see which trial which is actively recruiting for which specific cancer type, and then whether they are close, whatever, you can actually look it up. Then, of course, as a patient, if you would like to be in the trial, you can always go to the respective hospitals and then ask about seeing the doctor who's actually participating in the trial. Of course, if you're in a government hospital, then you can get a referral to go to the respective government hospital that is running the trial and get inquiry about it.
And all these drugs in this trial are like latest technology, newer drugs, and everything is free.
Usually in Malaysia, we will conduct clinical trials that provide the patients with free drugs. Sometimes there are trials where the comparator arm is actually chemotherapy drugs that is already a standard, but we would try to get the sponsors to also provide the standard. For example, if let's say we are testing an antibody drug conjugate versus standard chemotherapy in, let's say, HER2 positive type of breast cancer. So the standard chemotherapy, let's say the standard chemotherapy plus Herceptin is the comparator arm, then the new drug is the antibody drug conjugate XX. Then both of these drugs, whichever that the patient is enrolled to, is provided by the clinical trial.
Yeah,
so we prefer to do that.
Yeah, even the comparator arm drugs are always very expensive.
Exactly. So it's like, you win. Basically, you kill two birds in one stone.
Yes. So you get the standard of care, which is the expensive drugs, or if you fall into the investigator arm, it's a new drugs, which is proven to be good in phase 1, phase 2, and we're trying it on phase 3 right now.
Yeah, whichever it is, the idea is actually for the patient to benefit. Yes. So the patient will benefit from the trial. So we are the conductor, and we learn together with the patients, but I think overall everybody will benefit. The clinical trial is always good to be considered by anybody in our country.
Okay, that's good. That's good. So, is there anything you want to tell to our viewers about breast cancer, their treatments, from an oncological point of view?
I think from my point of view as an oncologist, has been in this industry for, I think since the year 2000, I have seen so much improvement in oncology, especially in breast cancer treatment. And so my take-home message for the patient in breast cancer is that not to be worried, not to have fear about breast cancer. And for those patients that those people actually who are out there, and please come forward if you have any symptoms of breast cancer, so that you can get it checked, you can get it detected, and get it treated as accurately and as rapidly as possible. Because no doubt we are talking about all these advances, but early detection saves lives.
True.
Okay, and spread the word, because it's so important that we spread important stuff. We don't have to spread about all these viral things that are not so important. But it's like, but I mean, this more important stuff that you should spread awareness about.
Which is backed by medical science.
By medical science, yeah, correct. Yeah, that's right. So yeah, so those are the two take-home messages. That means do not be afraid. There are treatment for you. Please spread awareness about breast cancer.
Okay. So thank you so much for being here today.
The Bald Oncologist podcast series